Thank you. Over to you, John. Thank you.
Okay, so you can see my screen. I confirm that. Yeah.
Yeah, absolutely. Yeah.
Okay, good. So thank you very much, Chris, for the invite to come and speak to you. I'm John. I'm a professor of exercise rehabilitation at Keele University, and I have about 20 odd years of frontline clinical practice, having had my own business for 21 years, and also working in cardiac rehabilitation, exercise referral within the Royal Shrewsbury Hospital for more than half of that, as well as various jobs of working in cardiac rehabilitation and neuromuscular rehabilitation in Oswestry at the hospital, at the National Neuromuscular Centre in London, and also here at Stoke-on-Trent in the hospital cardiac rehab. So been a bit about, but most of the time I'm an academic now, but I am moving back into clinical practice a little bit for a couple of days a week, which will be at the Royal Shrewsbury Hospital again, but and we'll be linking that in with my research. So the title is SIT, MIT, or HIT. SIT meaning sedentary, MIT meaning moderate intensity exercise training, or HIT, high intensity exercise training, titled Balancing the Physiological Intensity with Behavioural Sustainability. But before I move into that, just to say thanks to Chris for the invitation. I've had the pleasure and honour of sharing 3 publications, and I only worked with Chris for a couple of years, and in that time we have shared 3 publications of various things, from transoceanic rowing to high velocity power training in older people, and looking at the efficacy of wearable technology to enhance sedentary behavior analyses in adults. And in the last paper there, the self-reported device measured sedentary behavior, there's 2 authors on there from Ottawa in Canada, Stephanie Prince and Jennifer Reed. And just to say, I've just returned from working with them recently. And obviously we work very hard. So we go to the hockey game and sit. We have to sit a long time to wait for goals to be scored by the Ottawa Senators because they're at the bottom of the league. But on my left is Stephanie, and on the right is Jennifer. And Chris will have been working with them as well. Mitt, well, in the terms of ice hockey, the term mitt is the goalie's mitt, which he catches pucks with. And hit, obviously, there's a lot of hitting in ice hockey. But in terms of definitions for today, doesn't want to go ahead. Sorry about this. In terms of some definitions for today, I will be using the term of physical activity mainly for everything. If I use the word exercise, exercise is simply structured physical activity, but activity, all movements, whether we use them for transport, occupational, domestic, physical leisure pursuits, or structured exercise rehabilitation. They are all physical activity. So if I use the word physical activity, if we're talking about rehabilitation, I tend to tend to be related to structured physical activity. I'll be using the term MET, which is metabolic equivalence, and 1 MET is equal to the resting energy expenditure of a human adult, which is about 3.5 mils of oxygen used for every kilogram of body mass one has each minute. So we're all pretty much sitting. Some of you might be standing. Fit is the dose of activity, the frequency, intensity, duration, or time, and the type of activity. Sit, I mean being sedentary. And to be sedentary, one has to have an energy expenditure less than 1.5 METs. So if I now raise my standing desk and stand up for the rest of this presentation, then that means that I will now be at 1.5 or more METs, and probably a little bit more because I might move about a bit. So that's, I am now no longer sedentary, where the rest of you, if you're sitting, you are sedentary. So you're very welcome to stand up with me for the rest of this presentation. Moderate intensity physical activity training is typically what we have defined within our national guidelines for physical activity, and then high intensity training. So am I still connected, or it says connecting to audio?
You are, John. Yep, I can hear you.
Okay, I just saw Chiamaka come in, so that must have been there. Okay, so HIIT will mean high intensity physical activity training. So in terms of today's outline, we'll look at a few historical concepts of exercise and sports medicine, recent history, game changers in the last 60 years in terms of exercise, some exercise physiology issues, because what we have to remember is that lots of us like to study exercise physiology, but in fact, the science is pretty inert unless people actually get off their backside and start moving and doing it. And that's probably our biggest challenge, or keep people. And then I'll give you some examples of physiological gain being lost because of unsustained behaviors. So I'm going to have a bit of a go at traditional forms of focused, physiologically identified exercise training, and showing that unless we actually get people to do it, it is of no value at all. So if you suffer from chronic lecture fatigue syndrome, CLFS, you only need to focus on the next 3 slides, and then you're welcome to fall asleep for the rest of my presentation, because I'll give you the headline messages. So we have an ongoing story that if exercise were a pill, it would be the most widely prescribed medicine in the world. And this quote actually comes from 1978. Whether it has any evidence or not, it is widely used, comes from a book called Fit or Fat by Covert Bailey. But to make it work, if it is in fact parallel to being a medication, then there are 2 elements to ingredients to the medication. One obviously is exercise physiology, which we love to study, and in sport and exercise science we get very engrossed and detailed in this. But one area that we tend to leave to the side, unless we're specifically psychology focused, is participation behavior. But if we can get people to do any participation in more physical activity than they are doing at the moment, we know that there will be some health gain. But the other way around is that unless people actually do it, the exercise physiology is of no use. So really the message today is we really do need to make sure that we do focus on the behavioral side of activity as much, if not more, than the physiological side. But if I have just come back from Athens to the European Society of Preventive Cardiology conference, and there was a lot of physiological and issues around medicine, and not a lot around behavior. And there's this assumption that people will behave, but we know that most of them don't. So here is a recent small study that I was able to collaborate on with some people in Leeds. And we just looked at exercise-based cardiac rehabilitation. Is a little encouragement enough to get people? Well, what we found is that some encouragement compared to no encouragement in an exercise class setting was not even enough to get the verbally encouraged group to attain greater than 20 minutes at 40 to 70% of their maximal exercise capacity, or heart rate reserve, in this case, how we measured it. So even when we do purposely encourage people, sometimes in a clinical setting, we often don't get the desired behavioral response of meeting their physiological target. So exercise physiology, as I said, has no value unless you can get people to participate and stick at it. So historically, we have a nice story from Shrewsbury, Shropshire, and it is historically the center of the universe for sports medicine and physical activity. That is my wife. I always have to show her in photographs because I'm always accused of leaving her behind when I go to conferences. So that is Shrewsbury Square on a nice summer's day. And our story, as many of you from Wolverhampton will know, that the birthplace of the Industrial Revolution is just down the road in Ironbridge. But we have to also remember that that is the birthplace of inactivity and sedentary life. because prior to the beginning of the Industrial Revolution, the average person expended about 3,000 calories per day. And today, the average person expends about 2.5 to 2,500. So the differential between that is equivalent of a person in pre-industrial revolution times having enough activity in their life that was equivalent to walking 10 kilometers per day. So that is quite a bit of activity if most of us were to try and do that ourselves. And that's just day-to-day life. We know that Charles Darwin was born in Shrewsbury, and the concept of the survival of the fitter was actually shown scientifically for humans in about 1989 with enough data collected over about a 35-year period, where we see a dose-response relationship that the fitter you are, the longer you'll live. And we know that the people with the least amount of fitness, those people with a maximal aerobic power of 6 METs, that's not a very high exercise capacity. That means that people will get out of puff and have to stop if they can't complete 2 flights of stairs. So a person, if they have less than 6 METs of fitness, they will certainly reach their maximum level of exertion on doing 2 flights of stairs. But we see that if we improve their fitness even by 1 MET, we significantly reduce their risk of premature mortality. For many of you in the audience, you've probably got an aerobic level of fitness between 8 and 11 METs. And once you get to about 9 or 10 METs, there's no added gain in terms of life survival. So once you've got an aerobic fitness level of greater than 10 METs, there's no added benefit to your health. There might be to the enjoyment or the pleasure of being able to do your activities with much ease. But other than that, there's no added health gain to go beyond that. So we also know that in Much Wenlock, we had the birthplace of the modern Olympic Games with Dr. William Penny Brooks, and really he is a father of sport and exercise medicine. We see Wenlock, the mascot there with Usain Bolt at the 2012 Olympics. And interestingly, that I've just come back from Athens, having visited the Olympic Stadium in Athens, where the modern Olympics were rebirthed, but actually the idea didn't come from Greeks. It came from Dr. Penny Brooks, and who was recognized by Baron Pierre de Coubertin, who was the father of the modern Olympics, a Frenchman. And that's why you'll see the French flag and French as the official language of the Olympics. But the important thing is William Penny Brooks wrote to Parliament in 1890, and we still are failing on this message, that the school attendance is 3 hours in the morning and 2.5 in the afternoon. This would leave time to devote half an hour a day to bodily training. We are still failing on that simple message. He didn't have the science that we have now. We now know that most of us are recommended to do about 30 minutes of moderate to vigorous activity every day, which completely fits with what he was saying over 100 years ago. So the messages are the same. We have the science. How much more science do we need with all of this exercise stuff? Really, should we be shifting our attention to behavior much more? So if we travel forward in time to 1969-70, that's a watershed year for a number of things. First of all, the word aerobics was invented in 1969 by a guy named Ken Cooper. Those of you may have done the Cooper Run test, which is a 12-minute running test. And from the 12-minute running test came the 6-minute walk test. So essentially, he invented the 12-minute run test, from which some pulmonary physicians then adapted it to be a 6-minute walk test for pulmonary patients. But he wrote the book called Aerobics, which was adopted by many people. And we also see in 1969 Reebok already had their long distance running shoe being developed. Nike didn't have their waffle shoe until about 5 years later. So we also have people going back to the time of the turn of the century talking about exercise as bunk. If you are healthy, you don't need it. If you are sick, you shouldn't take it. That was Henry Ford. But we find that there's a Henry Ford health and fitness center in Detroit, and they're doing the exact opposite. So that's a nice turnaround. But also in 1969, we put a man on the moon, and there were 3 missions to the moon in 1969 to 1970. And during that, what often isn't reported is the health and fitness effects of living in less than Earth's gravity for prolonged periods of time, and in microgravity. If you're not on the moon and you're not on the Earth and you're somewhere in between, you're pretty much in zero gravity. So we now know the effects of that. And we now send people like Tim Peake and his mate Chris Hadfield from Canada. They're probably the most publicly facing astronauts we have in the world, who talk a lot about health and well-being from space flight. And there's been a number of studies, but this provides us with an excellent model for sedentary behavior. So if we want to look at the effects of sitting for a prolonged period of time, we can accelerate that by putting people into space, because they have no gravitational pull on their tissues, including their muscles, their bones, their heart, and their lungs, and their circulation, the factors which lead to disease in the future. So in terms of long-term space flight and that 6 months, that gives us a model for sedentary behavior. Now let's just look at this study of 14 astronauts who spent 6 months in the International Space Station. They would do 2 hours a day times 6 days a week of aerobic moderate to high intensity exercise training plus resistance training. So they're doing probably 2 to 3 times as much exercise training as is recommended by our chief medical officer and the World Health Organization. So let's remember that these guys, every day, they are doing 3 times as much exercise that's recommended. That's 22 hours. But what we have to do is we have to say that the 22 hours a day, they are in microgravity. So essentially, they are couch potatoes for 22 hours, absolute couch potato, because there's no stress. So when we look at the outcomes of putting people in space, even with a heavy exercise training program, to begin with, we see a 15 to 20% drop in their aerobic fitness, and they only gain about 1/3 of that back as a result of doing this training for 6 months. Then they return to Earth, and in their first 15 days of recovery, they gain some of that back. But even at 2 months after being back on Earth, they still, with all of that exercise training, they still have not recovered back to their pre-flight status. So this shows us a really, really important influence of how sedentary behavior actually, on a very small but very frequent basis, is just, if we're sitting too much, it's just reducing function in our body. And Stephanie, who I showed you, who Mike and Chris and I did a systematic review with, she has published recently this systematic review on the effects of sedentary behavior on cardiorespiratory fitness, and has shown that that there is a link between people's sedentary time and their cardiorespiratory fitness. So it's not all about doing moderate intensity to high intensity training to get your cardiorespiratory fitness up. For many people, even if they reduce their sedentary time, this is suggesting that that can have some benefit to people's fitness. We also talk about muscular fitness, and obviously this is a picture of me at NASA in 2018 meeting a real astronaut, and he's a medical doctor who's done 7 space flights, spacewalks, Steve Perezinski. And again, muscle strength is impaired, and full strength takes about 21 months to be regained after a space flight. So even though they're doing strength training in space, they are losing muscle fitness because of the very highly sedentary environment known as microgravity. So enough for rocket science. Let's talk about something really important. Let's talk about factors that influence people's behavior, physical activity behavior. So we've got genetics and social determinants of physical activity. Those are the two things that influence how we behave. And I want you to think of yourselves as agents for promoting active living, because many of you who are attending this talk are probably interested in physical activity and exercise for yourselves. And the reason why many of you are is either because there has been some social determinants in your life that have influenced you to be active, or in fact, you are genetically predisposed to liking exercise and or genetically predisposed to having some confidence and competence at actually performing activity. So this past year has been a significant year for me. This is my first year at school in 1969 and 70 in Canada. And last year I celebrated my 60th birthday with a bunch of my friends who are on the bottom. So these chaps that are on the bottom are in these photographs that you see here and up at the top. And it's quite interesting because the reason why we are all friends probably is that we all played sport together before school, at break time, at lunchtime, after school, either in an organized way, or we played actively all together. And our behaviors were already set probably by the time we came to school. And at high school, there's the tennis team again, with many of us there. So there was some sort of social determinants. And when I asked these guys, 50 years later, 55 years later, we're all still being active and playing sport and enjoying those sorts of things. So the social determinants of us at a young age seems to have carried through life. But remember, we only represent about 20% of the kids that actually are at school. So for me, the social determinants and genetic determinants is, there's my dad with his hockey team in 1948 at the University of British Columbia. He was the captain, he's in the middle there. And there's my mother, who's a public health nurse. And there she is at age 17, skating in the wilds of the French part of Canada with her sister. And again, throughout their lives, even when we were kids, they both continued to participate in exercise and sport, either with us or with their own friends. So, me personally, I was well set up for the behavior. So I want you to think about your own physical activity behaviors, and are you a representative sample of the population's physical activity? You might be. And when we talk about our statistics saying, that they're saying 60% of the people are meeting the guidelines, well, that's 60% based on self-report. We know that self-report basically doubles people's behavior to what it is actually. So in fact, the population is probably less than 50% of the population are actually meeting the guidelines. So which one are you? And what sort of social determinants have you had in your experience? Because we all have beliefs and attitudes, and these can inform an unconscious bias. So do our own physical activity experiences unconsciously bias our attitudes towards our patients or clients or participants in studies when we're doing these things? And the answer to that is yes. Our own beliefs and attitudes and behaviors as health professionals do greatly influence how we translate information to patients. And we may be as much a barrier as we are a help to patients in getting them to be more physically active, because of the way they see us and perceive us. And are we aware of what we are suggesting in all the things that we're not saying to the patients or participants in our studies about physical activity behavior? So one person that I have had the pleasure of working with is Professor Gunnar Borg, and who's the inventor of the Borg scale. And he was all about people's perceptions of exercise, how people perceived how hard they were doing exercise. And in fact, people's perceptions about exercise is probably a strong determinant of whether they do it or not. And there's a great book out there called The Psychobiology of Physical Activity. And I'll tell you a short story of how this is different than the biopsychological approach to physical activity. So what I'd like you to do, if you're a promoter or an exercise coach or involved with helping people be more active or doing research, we can take two approaches. We can take a prescriptive biopsychosocial approach, or we can take a guiding psychobiological approach to getting people more active. And these are, though quite subtle, a subtle but significant difference can be influenced behaviorally. So what we often have in our guidelines for exercise testing and prescription is we are told that we must screen patients for exertion, safety, and risk. We assess their physiological function. Based on that, we set people's intensity, and then we build a program of frequency, intensity, duration, and type of activities, and we build in progressions. And that's the model that we tend to follow where in lots of arenas, whether you're a fitness instructor, a rehabilitation specialist, we tend to tell people to follow this. And then what we do is once we've determined the prescription for that person, and we think it's very individualized, we then try to find ways to motivate people to adapt their current behavior to meet this principle. So what we forget about is we're trying to fit that person and their behavior, their beliefs, and their attitudes towards something that all of us are probably quite comfortable with, but they aren't. So there can be this idea of you're actually probably trying to put a square peg in a round hole with that. And I'm going to show you the data is that most of the time, in fact, that actually fails. So if you take a psychobiological approach, it does certainly screens and assesses people, but it first of all screens and assesses people for their psychosocial risks of not being active or not taking up activity. And how much do we address that? Because unless we can determine if people are ready and how they believe their readiness to be active, unless we take that approach, then everything else will be a waste of time. We need to assess people's beliefs and attitude, create barriers to their participation and all the social things that are challenging them. And then we have to make a determination of what are the chances of increasing this person's activity and which will have a higher chance of sustaining. Now, in the world of smoking cessation, we do an analysis of people and we simply say, is this person, has they got any idea of or inkling that they'd like to stop? And if the answer to that question is yes, then you move forward with a program to help them stop smoking. But if people are so hell-bent on not stopping smoking, sometimes we don't waste our time at that point in time, but we then have a coaxing program, hopefully, that's going to get them to even change their beliefs and attitudes towards it. And then once we have determined where the person is ready, then we can do assessments of their physiological function. We can set the limits for safe and exercise intensity, which is a ballpark in which they should be active, see which patient lifestyle activities may actually help achieve those fit targets. So we don't necessarily need to give them an exercise program with equipment or a class. We could actually look at what happens in their day-to-day life that might challenge them enough to actually get fitter. And then maybe after that, explore ways of structuring that. And it's a step-by-step process. But even by getting them more active, even if they aren't meeting our physiological targets, as I will show you in some of this following research, there will be some gain there. So there's a nice study at in 2002 that showed this around an exercise referral scheme, and they took 370 adults, healthy individuals who had been referred for exercise referral, and they're obviously willing to participate because they accepted the exercise referral. And one group was randomized to a fitness assessment where they do the traditional fitness tests and health tests, blood pressure, lung function, skin folds for body mass index, and aerobic fitness and strength. Another group that was referred to an exercise consultation arm of the study where they simply got behavioral support and they were simply asked to, can they make adjustments to their day-to-day life where they could build in more physical activity? And then obviously there was the control group who were given standard leaflets that promoted the national health recommendations for being physically active. So after 3 months, all of those three groups had increased their physical activity levels from baseline, whether they'd had a leaflet, whether they had a fitness test, or whether they had consultation. At 6 months, both the fitness test group and the behavioral change group had maintained their fixed physical activity, but only at 12 months did those who had the exercise consultation, were they still maintaining their physical activity behavior? Now, they may have not been maintaining their physical activity behavior to the level of the exercise group, but the exercise group pretty much had relapsed and were not exercising anymore. So any activity that this behavior change group was doing was better than doing no exercise at all. So only the group that had some behavioral support. So just showing the importance that behavioral support has. So in 2023, the American Heart Association seems to have woken up and smelled the coffee and raised the issue of new paradigms to address long-term exercise adherence, calling it an Achilles heel of lifestyle interventions. So for the last 50 years, our model for delivering and promoting exercise hasn't really changed behaviors at all. So we're just following into what Albert Einstein was saying, is being insane because we're trying to do the same thing over and over again and expecting different results. And in 1997, at the American College of Sports Medicine, I attended a conference and went to a workshop with the Project Active group. And that Project Active group was similar to that study I just showed you in Glasgow, and was sort of the leader of that. And they took, again, two groups. One group got the structured exercise fitness program. They got 6 months free membership at the Aerobics Institute in Dallas, which was started by Ken Cooper, as I showed you in our first slide. And then another group met for a physical activity lifestyle consultation group and had that behavioral support of how they could be more active in day-to-day life. And you can see at 6 months, the aerobic fitness group who went to the gym, they improved their aerobic fitness by significantly more than the structured lifestyle group. But the structured lifestyle group had improved their fitness, even with just doing lifestyle activity. But when you look at the two groups at 24 months, there is no difference in their aerobic fitness. And in fact, the gym group's fitness had dropped considerably compared to the lifestyle active group, who had maintained their behavior. So I've experienced that in my career. And I said for 21 years, I had my own fitness center that was in Shrewsbury, and these are my physiotherapy partners. And we ran an exercise referral scheme in cardiac rehab at the Royal Shrewsbury Hospital. And two people in the picture on the other side of the treadmills is Gareth Mapp and Gordon McGregor, as young exercise physiologists training back in the late 90s. You know, I finally, it took me about 10 years to realize that trying to push the message is hard. So what the aim is, we shouldn't pushing your story uphill, or do you build a community that will help pull people up the hill? And so in terms of attitudes and beliefs towards coaching exercise, from about 1999, I then had an epiphany that I needed to change things. And in this textbook I wrote with Gareth Mapp and Jane Holmes in 1999, our second chapter was on behavior. And that book was cited in the National Exercise Referral Systems Guidelines of the NHS. And I also edited an exercise physiology text, but I remember getting a comment back from the editor saying, John, this isn't an exercise physiology text because your first chapter is on behavior. And that's what I said. I wrote back and I said, yes, all of the physiology that goes on from chapters 2 through 13 will be a waste of time unless we deal with behavior. So you can see that in chapter 1, increasing and maintaining physical activity was a key feature of chapter 1 of an exercise physiology textbook. So how many of us in this presentation seriously help patients plan beyond a 6-month experience of gym fit classes? Because most of our rehabilitation, even when it's done remotely at home now after COVID or whatever, how much of us actually ask the question is, what have we done to educate and coach patients to maintain their activity for a long term beyond the 6 months that they will probably leave our influence or guidance? Have we changed and coached them behaviorally so that they will be active for the long term? So here is the first randomized controlled trial in cardiac rehabilitation in Stoke-on-Trent from the UK. And we can see that, yes, the fitness group, which is the black line at the top, got so much more fitter than the control group. But at the end of 3 years, the level of fitness in the two groups was no different. So what was the point of doing the cardiac rehabilitation in the first place? Here is a study in terms of people with pulmonary disease, chronic obstructive pulmonary disease, and you can see compared to the control group, yes, at 6 weeks after rehab, they'd improved their VO2 peak and their 6-minute walk distance performance, but after 12 months, they had lost that, obviously because they hadn't been active. Similar, the largest trial in heart failure in the world, which is called the HF Action Trial. They had 935 exercising patients complete the study. Only 25% of them adhered to the 90 minutes per week that was recommended for them. 15% partially adhered, but 60% were poor adherers. So over 60% of the participants really did not meet the requirements of the study design to influence the outcomes for heart failure. Now, in those who did adhere, if there's subsequent publications, they did certainly show great benefits in terms of their health, their cardiac function, and their cardiovascular health compared to those who didn't. But again, it's showing that the pill is very effective if people take it, but if people take it, the pill has no effect at all. So cardiac rehabilitation, again, has received attention. And here is, again, a treatment and a control group. And you can see that even in the control group, who was given advice about being physically active as opposed to a structured exercise program, improved equally compared to the intervention group. But when we look at the aerobic fitness of the groups at the beginning of the study, their VO2 max was only 14 to 15. So they had a very low VO2 max, or equivalent to 4.3 METs. So any activities in daily life that they did above simply standing were probably moderate intensity to vigorous intensity exercise for everybody, whether you're in the control group or not. And so what happened was, in this case, it looks like the control group did do some activity which was equivalent in intensity to the intervention group. So it goes to show that about lifestyle activities that people can do, which actually in many cases with these older, low fit people, that they will actually get equal fitness benefit compared to what we're doing in the official exercise classes. Here is a more recent systematic review looking at high intensity versus moderate intensity continuous training in people with heart disease, coronary artery disease, and heart failure. And it shows that within the first 8 weeks of the program, certainly the people who did the high intensity program physiologically were significantly fitter than those in the moderate intensity group. But after 8 weeks, the moderate intensity group's fitness had caught up to the high intensity group. So a bit of a tortoise and a hare scenario, that the high intensity really in the longer term wasn't any more beneficial than the moderate intensity. Here is adherence to behavior change supported by behavior change coaching. And you can see in both resistance training and cardiorespiratory endurance training, in all across, there was a low uptake and adherence to the program in both groups, but it showed that in the higher intensity programs, the main point of this, in the higher intensity programs, even with behavior change coaching, behavior change support, BCS, the high intensity groups had a lower adherence than the low intensity groups without any behavior change support. So the fact was that the people were doing exercise. It might not have been at the ideal or target intensity, but they were actually, in terms of doing activity, they were doing more activity than the high intensity people. And then this is a very good study done by our colleagues out of Coventry, Gordon McGregor's, and various others from Leeds and Cardiff. And they had, it's called the hit and miss trial, and the high intensity versus the moderate intensity group. And they, again, showed that in the first 8 weeks of cardiac rehabilitation, you can certainly see the high intensity group is doing better physiologically, but after 8 weeks, the behavior change either didn't change any further, their fitness didn't change any further, and yet the moderate intensity group was still on the rise, their fitness was still going up. So again, they were achieving, after 12 months, this a raised level of fitness. We actually know that on the right-hand graph that the high intensities group behavior dropped, because this is the amount of oxygen that they're using at their anaerobic threshold. And one of the markers that we have of physiologically of people's activity levels is the more active you are, the higher amount or higher proportion of your aerobic fitness you can use and sustain. And if that level drops, we know that your levels of training have actually dropped. So we can see that the behavior did drop in the high intensity group, where it was maintained, and it was still on the way up in the moderate intensity group. So it looked like, oh, in the longer term, the moderate intensity group are achieving the same improvements in fitness, maybe at a slightly slower rate, but they are sustaining those. And there's some data then we're getting close to the end, and then we'll have about 7 or 8 minutes for questions. This study from a group in Leeds, and they had an exercise referral post cardiac rehab service, and they'd followed patients for 12 years who were continuing to exercise, and they showed that the exercise dose, met hours per week, appears less important than long-term adherence to supervised exercise. So they're simply saying, if you adhered to your supervised exercise program on a regular basis, independent of the intensity and duration, that had a stronger association with your long-term mortality risk compared to just looking at the FIT principle. So they recommended that extending supervised cardiac rehab programs within the community plays a key role in promoting long-term exercise maintenance and secondary prevention. But it almost doesn't matter as much what people are doing in terms of intensity and duration and type of activity. What is important is that they continue to be active on a regular basis. Okay, so I'm going to move to finish off here, looking at activities in daily life and how we perceive activities in daily life, and then I will finish off. So finally, this is a recent paper that came out in the British Journal of Sports Medicine, and everybody's wearing wearables, technology, especially people who like to go to the gym. So they surveyed people who went to the gym, and they asked them, how much time yesterday did you spend exercising? And they, on average, said 60 minutes, and they said 60 minutes of vigorous activity. But when they actually looked at people's devices, they were only doing 25 minutes of vigorous physical activity. So people thinking they're doing 60 minutes, but they're only doing, actually what was on their monitor was only 25 minutes. When they were asked outside the gym, how much vigorous activity did you do yesterday? All of them said, I don't do any vigorous physical activity outside of the gym. But when they looked at their devices, in fact, on a daily basis, they were doing 10 minutes of vigorous physical activity. which means that that a third of their vigorous physical activity occurred in activities of daily living, which means that if we focused on activities of daily living a little bit more as a place where people can do more physical activity, we may find that we can get people to achieve the recommended guidelines for rehabilitation or public health, whichever we're focusing on. So I'm going to finish off now by just summarizing those, and I will send you these slides so that you can see the rest of the slides in the end. So the first thing is, are we appropriately gearing people's behaviors up for sustainable behavior in physical activity and exercise? I've tried to do my best to enter these concepts into two key areas which I've been working more recently. So there's a recent textbook by the BACPR for cardiac rehab practice. And last year in July 2023, I had the pleasure and honor of being part of the WHO's panel of 15 who wrote the package of interventions for rehabilitation in cardiopulmonary conditions. And I'll be returning to Geneva in about 3 weeks' time for the next annual meeting of this group. So physiology is interesting for practitioners, and it is important in physical activity that it's safe. We know that we can get patients to do things and that will be safe. Physiology is inert if we can't get people to do it. Your own experiences and attitudes to physical activity can sometimes be a barrier to helping people. And finally, for those of you studying, working hard, wanting to progress in life, take your work serious, treat your patients and participants with respect, empathy, and precision, but in the process, don't take yourselves too serious. Thank you very much.
Thanks, John. Absolutely great. Pleasure to hear you speak as always, and to hear what you've been up to. I'm just going to throw this open to the guests in the room. Has anybody got any questions for John? I don't know if you want to just come on camera or come onto your mic, or if you prefer just to pop something in the chat, equally happy for you to do that. Any questions for John at all?
Oh, hi. Yeah, I've got, I'm not sure if it's a question, because I think I found it very interesting. I'm sorry, I'm Mark Chrysanthou.
Yeah.
Just towards the end, you were kind of touching on the question I was kind of burning away at me during your talk, which is, coming at it, I think, very much from a kind of ecological perspective rather than an individual patient to health professional perspective. I just feel that there is a much bigger role, if we're talking about creating a sustainable exercise activity amongst the population that is going to prevent some of these, heart conditions, cardiovascular problems, etc. We need to do something more about the ecology of our societies in terms of, the architecture, the design of environments, but also I think culturally, because I always think outside of the kind of gym bunnies or whatever, the kind of lycra clad images you always see, that's almost a bit of a off-putter for many people. If we started reimagining exercise as play, it's almost like when we grow up, we stop playing, or we stop. I think, we need to almost like rebrand exercise as fun or play, and I think there's a bigger role for incidental exercise, whatever you're doing, it seems to me the more we move, whatever we're doing, whether we're doing it vigorously or self-consciously as exercise, everything has to be a benefit, really, doesn't it? If we get people moving more, and if they're enjoying the movement and it's, more fun, I think that's the way to go as I see it, rather than just focusing primarily on quite niche level kind of intensity programs for, specific individuals.
Yeah. So you are correct, and that goes back to the very first slide, saying that the cause of the problem is inactivity in people's day-to-day lives because of the Industrial Revolution, not because of people participating in less sport or exercise in a socially constructed concept. And the other thing is, you have used the word exercise continuously in your description. Why not just say get people to be physically active or active? Because the word exercise in itself could be the barrier. because people have that perception of what exercise means. So, this whole idea of being active in life maybe is what is the approach that people are actually taking. But reconstructing the environment, it's the construction of the environment that's caused us to be social and physical environment that's caused us to be sedentary. And we've shown that. I mean, it's not as simple as smoking. One of the reasons why smoking cessation programs are so successful is that when people are discharged from a smoking cessation program, the environment, the social environment which they're released into after that, is supportive of that behavior. Where in 1970, 50% of the population smoked. So the environment which people went into after they did a smoking cessation program was that most of their friends were still smoking, and that where they went socially, people were smoking. So it was very difficult to stop. So we have changed that social and physical environment for people who's smoking. So I don't know how we reconstruct the environment to make people more active, but it's going to be a big job.
I was going to ask you about that actually, John. What sort of were your ideas for that? I mean, I really sort of resonate what you're saying about the psychobiological model and identifying, where people have opportunities to exercise. And I know that from some of the work that we've done together, where we've, speaking to an individual client or participant and identifying that is quite straightforward. But, from a public health perspective, how, for example, the city of Wolverhampton, if we wanted to make them more active, is there a way to upscale that psychobiological model to have a population level increase in physical activity?
Well, we can start with the people. There are people going through your hospital in Wolverhampton for pulmonary, cardiac, cancer rehabilitation, and they do say yes, and they do take up their exercise program for the time being. And so we do have a group of people there that have at least considered doing this. What we need to do is possibly change the way we deliver those programs that may be more focused on getting them to think about being active in the long term. It's great to do the studies on the HIIT being physiologically beneficial, but all the evidence shows that nobody is sustaining that. We're putting a lot of energy into that, trying to make it safe, have high level fitness tests and medical tests to make sure that they're safe. And yet in the long term, does that relate to what we actually want people to do? And could we spend a bit more time looking at their long-term behaviors, simply so that they don't have to think about that they have to have a fitness instructor to do this. They don't, all those sorts of things that happen. And I still don't believe we do enough to help people achieve health and exercise professionals achieve that either.
And could I just come back to your point there quickly, Chris? Sorry, I'm not trying to take over. I think when you talk about what you talk, when you say what can public health do, I mean, ironically, I came from Shrewsbury in Shropshire, so I know it quite well. But I also have lived in environments where I know that the kind of environment has been totally unconducive to exercise in terms of things like green spaces, cycle networks. I recently went down to Lewes in East Sussex, and I was just kind of amazed just how many freely accessible parks there were, and people were playing with their kids, and people were throwing balls around in spite of the sign saying no ball games on the grass. But the whole environment, I felt, was just much more conducive to I'm going to say an Australian style culture, a more culture of people actually demonstrating publicly a kind of physical lifestyle. Whereas I feel like many urban environments like Wolverhampton, they lack the green space, like Central Park in New York, where there is a kind of embodied culture where people come and can take part in whatever the activity is, whether it's juggling, whether it's riding a bike, whether it's just walking the dog.
Okay, well, I said, Mark, there are some things going on in Shrewsbury about active transport, but I see John's point. But thanks for commenting, Mark. Yep. Jennifer, I'm just going to come to you. See your hands up. You got a question for John?
Hi, Jennifer Lim. My interest is in dementia prevention. So my work is a lot into with what we call here the minority ethnic groups. But in particular, I'm currently working with the Chinese population and also at the international level with people in Malaysia. So my interest is really into trying to set up at the moment a kind of an intervention at the community level, doing a multi-domain intervention, physical activity, diets, that kind of things to improve cognitive function. So, I mean, I actually get it when you said that, it is hard to get people to participate. And obviously, people who are participating in a kind of intervention or kind of study would be people who are really interested in that topic, right? So, but that is the start of it. So the other thing that you were talking about was that sustainability, and then you were talking about the behavioral support, behavioral change support. So I'm really interested in what kind of things that you guys have done with regards to behavioral change support, and then how to get that sustained. Because I just cannot, I'm kind of thinking, right, if you're doing things at the community level, how to then, sustain behavior after 6 months, and maybe trying to learn from you, what you have done to do that in your studies.
Yeah, I mean, one of the things I see lacking in our training around physical activity and exercise is a strong presence of social and psychological scientists. And when we have students coming to study sport and exercise science, it's all on the biomechanical and physiological aspects. They all get really excited about that stuff, not so many on the psychological and the social aspects. And yet those are going to be the challenges that they talk about for the rest of their lives. And they've never really had any training in them. And we saw that in COVID. We had a whole bunch of people then were forced to think about the environment and the social and the psychological elements of people being physically active. And it just escalated and accelerated people's focus on. And people were coming up with all of these wonderful ideas to try and get people to be active. And yet they were doing it without using any science. And again, even with the rollout of our vaccines and the behavior of our population, we had the chief medical officer and the chief scientific officer, but where was the chief social science officer in those discussions? Because the biggest challenge we had during COVID was people's behavior, not we got the medical stuff. But, where was the strength? Or were those people hiding in the background but those people weren't front and center. We often, because maybe it's not sexy, because it's not medical, you can't put numbers to it as well. It's things like that. We tend to get caught up in that. And I'm just telling you about my failings that I've spent the last 20 years saying that, physical activity and exercise is not a medical, physiological treatment. It is a behavioral therapy. And that is the biggest problem. And we see that all the time.
Right.
So I think in our training of people who are involved with exercise, I think psychology and behavioral sciences and social science should actually be the underpinning information that they get, not bones and muscles and hearts and lungs and circulation and all that sort of stuff.
Yeah. Would you agree that we have very low knowledge of the type of activities to do that would benefit us? I know that, you started off by saying that, those of us who are here are actually people who are already into physical activities. I am actually started off being very active as a child. And where I come from, we are always running around, with no restriction. I mean, when I came to this country, it's a lot about, the weather that kept people at home. And then now, because of the technology, children are staying at home a lot. But I noticed that a lot of young people are actually going to the gym, but just for a certain reason. But for people in our age group, like, maybe 40s to 60s, there are less of this kind of physical activity. So what I'm just thinking, would it be that people have, even like, for example, someone I know who has got, who is pre-diabetic at the moment, and he is really taking a lot of, doing a lot of exercise, reading, and understand the type of activities that he would do to reduce this, him from being a pre-diabetic stage.
Mhm.
So I'm just thinking that, learning from this person is that there's a lot of, I myself, I don't understand, I don't know, I have poor knowledge, I would say, at this point, is that the type of activities that I need to do actually that would really benefit to me to reduce maybe my blood pressure or, that kind of stuff.
Okay.
And
Well,
what
we
they
have
eat.
we do have the answer to those questions. The biggest
Mm.
challenge is getting people to do the exercise that we need to do. So on that front, they have it. The information is pretty much there, and we're gathering more information on dementia now in terms of. So we still have to do the physiological science, because we have to test whether it actually works or not. But but in most cases, we've shown that with all of these different conditions, we've got a very strong benefit from people being active.
Yeah.
So we know that, and we probably don't have to really do much more physiological science on that front yet. We continue to do it. Maybe if we get more people active, we can start to worry about what they're doing to get more. But
Yeah.
at the moment, getting more people just minimally is actually the biggest challenge.
Thank you very much. I really enjoyed
Thank you.
listening to your presentation, and it actually helped with my idea of developing this study. Thank you very much.
Thanks, Jennifer. I'm just very conscious of the time, that we're already over time, and I know that John is very busy, as I'm sure a lot of colleagues are. So I'm going to draw it to an end. Thank you, but say thanks very much, John, for coming along and speaking today. So it's always a pleasure. If you've got some free time, I'll give you a quick phone call now for a brief catch up.
Yep.
I know we didn't get to do it prior.
Or we can just stay online if you want. So
Well,